Do you want to just show us the difference? We've brought your samples with us. So that's a speculum.
So this is a speculum. This is an instrument that's often cold and uncomfortable. And for a pap smear to be done, a woman needs to be lying down on bed in quite a vulnerable position and have her hips abducted, that means open wide, so that the healthcare professional can then put this instrument in to visualize the cervix and then take some samples from the cervix, which is the neck of the womb where the baby comes out. So we're all made of different sizes, and some Asian women are slightly smaller, and this can be quite an uncomfortable, if not painful, procedure.
There's only one size?
No, there are many, but in real clinical settings, sometimes there's only one available.
And can only a healthcare professional carry this out?
So that depends where we are. So in other lower income settings, it may be a community health person, but in the setting of Malaysia, it's usually a doctor or a nurse. So that's that. And to do this to scale, you really need to have beds everywhere, a private setting, nurses or doctors available to screen every eligible woman at least once every 3 years. So in terms of infrastructure and human resource, it needs a lot of people. And then someone will have to look at the cells, which I'll leave it for Marion to describe later on. So with the advent of COVID, everyone understands what a swab is and what a PCR is. So essentially, the new method we're talking about, we've talked about self-collection, self-testing, self-swab. What it means is that a woman can essentially use a swab such as this, insert it into the birth canal or the vagina. So this doesn't need to reach the cervix. It just needs to reach the lower part of the vagina, where she then takes a sample and then put it back into this tube, and a PCR test will then identify whether there's a presence of an HPV that's associated with the risk of developing cervical cancer.
Okay.
So 2 of these tests a lifetime, as opposed to 15 of these tests in a woman's lifetime.
And if you're not comfortable doing it yourself, you can actually get a healthcare professional to do it for you as well.
Of course.
Okay. And are women open to self-sampling in Australia, Marion?
We are seeing a great uptake of self-sampling, and I think it's partly because it's positioned as a choice and people are finding that very empowering. Our early data are suggesting that it's being taken up disproportionately in the very communities we want to reach. So that's in our Aboriginal and Torres Strait Islander communities, in our remote locations, and amongst people who are residing in areas that are associated with poorer access to resources, lower socioeconomic areas. So that's fantastic. We still have some barriers, which are a little bit ironic, that the least uptake of self-collection is in our most affluent areas, where some of our GPs still don't understand that this test is as good. And they are thinking that this is a test that's only for people that won't have a clinician-collected sample. So every country and setting has its own challenges. And for me, I'm not concerned too much about that, except to say that in those practices, there will be people who would have appreciated the choice, who perhaps aren't being given the choice at the moment. And that's the role of practitioner education that we have to do in Australia.
I think as a clinician, as a doctor, as a gynecologist, this tool is my most basic tool. I've been taught to use this for many, many different procedures. I understand it's difficult to say this may not be necessary. I mean, most of us in medical school are taught to insert a speculum, and as far as we know, as long as we've known, visualizing the cervix, to see if there's any abnormality, then taking a sample is best practice. And to now say that you don't need to look at the cervix, to then take a swab, not from the cervix, from the lower vagina, is a huge step of faith or even a huge paradigm shift. But the evidence is very strong. The evidence is there. Look at the evidence and it will tell you that an HPV test done correctly is actually superior to a pap smear in the best of settings.
How do we shift our mindset that it's going to be much more costly? At this point of time, a pap smear is so much cheaper, Professor Wu, versus doing an HPV test. Affordability is a problem. How do we get around this problem?
I think we need to look at how much we spend or we invest in a woman in her lifetime. When we look at pap smears, we always look at it as a single test in a woman's lifetime. If we were to look at it as a protection throughout her reproductive years and as she's living, as she ages healthily, then we need to look at the investment in pap smears and HPV testing, and multiple studies have done. Those clever people with calculators, with maths and modeling have shown in all settings, whether it's a low income setting or high income setting, changing over to a HPV test is cost saving. That means it even works out using less cost to the government than pap smears.
I think that's right, and my background actually is as a cytopathologist. So prior to all these changes in the technology, I spent my professional career reading pap smears and running a very big lab in Melbourne that does 300,000 pap smears a year before we switched. And I know the amount of resource that it takes to do that accurately and to maintain high quality. It's very challenging and it's very costly in human resources. So I think sometimes governments look at the cost of proprietary consumables like an HPV test and they don't go back and say, well, how much are we spending on our laboratory staff doing these tests multiple times in a lifetime, and how much value are we getting from these tests? Because if they're not done at high quality, if they are truly very cheap, then I would have a concern about what's the quality, because you really need a person looking for a certain amount of time. They need to be well trained. You need to monitor their quality. So I think all of those things come together. And as I said, I'm a cytopathologist. I've sort of blown up my own profession.
I was just going to say,
Australia.
Your income or how you would...
Our business model was completely disrupted by this change. And yet at the Australian Centre, we advocated for it strongly because we believe we're here for a purpose, and that purpose is to prevent cancer. And I want to be really clear that high quality cytology has saved multiple lives over the years. It was important work and it was the best we had at the time. And so I'm not saying that was wasted time, but I am saying now there's a better tool, and we have to be honest with ourselves and think about what's best for the communities we're trying to reach, not what's best for us as providers. And so that's why we really advocated strongly and worked with the government on advisory committees to give effect to this change that is putting Australia in a position where we might be first in the world, because we are reaching more people with a better test. And it's so exciting. But I'm not going to lie, it was really, really challenging. And it made some of my professional relationships not as collegial as I'd like them to be. And we were talking on the way over here too, that I used to have 50 highly qualified medical laboratory scientists who specialised in cytology. And we now have 12. So 38 people. We had to go through a process over 2 years about timing their retirements if they were going to retire, helping them develop their skills to work in other areas of laboratory science or in other related fields, and supporting them in other qualifications. And, I think at the end of the day, we have to do what's right, and we have to treat our workforce with compassion. but we can't make our decisions about how we spend public health money based on preserving jobs for people. That's just not the right choice.
I mean, we are in an era where we are reskilling and upskilling, and it's just one of those things, isn't it? We all go through it. When we talk about artificial intelligence and how it's going to displace a whole load of people, it's similar, right? It's all about retraining and finding your ground.
And I just want to say that one thing that's not talked about a lot in low resource settings, but I am aware of, is the shortage of qualified staff to do lots of things. So these people who are trained as cytologists, they've got great medical laboratory science skills. They can be redeployed in a number of different areas within medlab science, but they also can do other things like data management, health information management. Some of them have population health qualifications. So I think it's really important that we acknowledge that I think it's very unlikely that we're going to have a lot of unemployed people. We're going to have people who are going to go through change, which is going to be difficult. And when they're on the other side of it, I think they'll feel better about it.
The transition
is always painful.
It is very painful. And how long has it been since you introduced this in Australia?
So we switched at the very end of 2017.
And that's the same story with clinicians and doctors as well. We are creatures that don't want change. We're trained in a certain way. I'm trained to do pap smears. I'm trained to do surgery for cervical cancer. And as a gynecological oncologist, that's really my rice bowl. And to say that, I'm now going to give you a swab to do your own swab, and there's a probability that I'm going to be irrelevant, that's something that I have to think about, and how do I change my role in healthcare?
Yeah. What do you think? Where do we even start in Malaysia?
I think we're at a good starting point.
Yeah, we've done well with vaccination. We need to now build up the screening and the treatment part of the elimination program. How do you think we can do that?
I think Malaysia is in a very good place. There is political will. I mean, for our government, our Ministry of Health, to change their guidelines, to say that, yes, we are going to move with HPV testing. Yes, we are going to do self-sampling or offer self-sampling. That is even a point where many countries are trying to achieve. Now that we've take this little step forward, the question is, how do we get buy-in from healthcare professionals? How do we re-educate our women? How do we remove those fears? And that's where I think a call to action for everyone in Malaysia is necessary. Not just doctors, not just public, but even the financial sector, even the hospitals, how we do billing, how we package care. We do need to re-look at all that. How do we say cytopathologists, yes, you can be doing other cytopathology work in the laboratory. Okay, these machines, let's share them. You bought them for TB and HIV testing, but can you now use them to do HPV testing? I know we're very territorial, but let's look at ways to share these machines. We have resources. Sometimes I think that it's the way we separate our departments and our work description. I think we need to be innovative and change some of these policies, and it may not require so much investment because they are there.
We did a lot of PCR tests during COVID, during the pandemic. Can those be used?
I think if we look at it correctly, they can be used, and it's used in many countries, because if you think about the flip side, we've had all these machines and we use them for COVID, and these machines are used for PCR. So choosing the right machine, we can definitely utilize these machines for HPV testing.
And as a pathologist, as long as these instruments are clinically validated for HPV testing, that's great, because then you don't have the capital expense of buying the instrument. You're then looking at the consumables cost for new tests.
What's clinically validated is what my colleagues ask all the time, Marion.
So HPV testing is interesting because unlike when you do a COVID test or other PCR, you're just looking for the presence of what we call a pathogen. So that's a virus or a bacteria or similar that can cause disease. But with HPV testing, because this infection is pretty normal and common, we're looking for enough of the virus being present such that studies show it's associated with pre-cancer at a certain level. So when we have HPV tests for primary screening, we need either trials that demonstrate that it's sensitive, meaning it'll pick up a problem if it's there, and as specific as possible, meaning you don't get too many positive tests when there isn't a problem there, for the detection of pre-cancer. So we either need those trials or we need comparisons with other tests that have been in trials, and we need to demonstrate equivalent performance. So there are an international group of experts that have a set of criteria that the new tests have to demonstrate that they meet those benchmarks and they're suitable for screening.
So it can be done.
It can be done, definitely. And there's more than a dozen tests on the market internationally, close to 20 that have been clinically validated. So there is a lot of choice, and it's also important that we don't let cost drive the selection of tests that are cheaper but not clinically validated. That's really important.
And in terms of budgets, Marion, I mean, how did Australia convince the government that this is where we should be investing our money in? I mean, how did you put that discussion forward? Because I mean, you've got so many diseases, fighting for the same pool of money. I mean, Malaysia's seen a hike in our healthcare budget this year, and it's significantly higher, but everyone's scrambling for the money. I mean, everyone's health is important, right?
Yeah.
So how did you put your case forward?
So the way it worked is the Australian government actually undertook a health technology assessment. And that means that the cost and the benefits of screening with pap smears was compared with the costs and the benefits of screening with an HPV test. Now, I've been involved as an expert on these committees for a couple of decades now. I've seen many applications for new technology to improve the accuracy of screening by cytology, none of which have succeeded in the Australian context. And this is the first time in my life. So to answer your question, what our government and many governments do is we compare the cost per life year saved. And that's how you can compare the investment in screening against improving neonatal health services. And there's usually what is called a willingness to pay threshold that most governments have. So not only did this switch make that hurdle, but in fact, what was shown with the cost effectiveness analysis is the cost of screening with HPV, even taking into account the extra costs of the test, was less expensive over the lifetime than the cost of doing cytology because of the number of tests required in a lifetime. So less expensive and more effective. And you just practically never see that. In health economic terms, I've never seen it. It's definitely a unicorn to have something that works better and costs less. And honestly, there aren't health ministers or governments that are going to say no in that situation.